Hi, my name is Hal Para, and today I'll be presenting my project on delirium prevention in pediatric patients. So what is delirium? According to the DSM-5, it is where there is a noticeable, discernible change in a person's neurocognitive baseline, which is apparent in the change in their attention span, cognition. They may seem irritable, not themselves. Their level of consciousness may be affected as well. And all of these symptoms are not caused by any other medical condition or pre-existing neurocognitive condition. So delirium in our pediatric patients. So a lot of times what we're not aware of is we often think of delirium in adult patients, elderly patients. We don't realize that our hospitalized pediatric patients are also at risk for delirium. And in this patient population, they can suffer from 3 types of delirium: hyperactive, hypoactive, and mixed. And that's pretty much self-explanatory. Hyperactive is where they're up, they're hyper aware all the time. Hypo is where their level of consciousness is diminished, where they're not as awake, they're fatigued, and mixed, a little mix of hyper and hypoactive. Some of the symptoms that they may display that families and nurses should look out for is altered mental status, confusion, disorientation, irritability, any sort of emotional disturbances, sleep disturbances, and they can also have delusions as well. Delirium has been found to affect anywhere from 20 to 40% of PICU patients. And a lot of times it's because PICU patients are acutely ill. Also, it can be a result of worsening clinical disease. Sometimes the pediatric patients are at higher risk because they are on a lot of medications, specifically benzodiazepines, for instance, and they are subjected to a lot of sleep disturbances due to nursing care, labs, medications, etc. So the unfortunate thing is that delirium can result in significant increases in patient care costs. The hospitalization stay can be lengthened, and you can see an increase in morbidity and mortality rates in our pediatric patient population. So the objective here is, like I said, not a lot of people are aware that our pediatric patients can suffer from delirium. So we want to increase awareness and education among hospital staff members, anybody who works with this patient population, specifically the patient family, just because they are around their kids the most. They know what their child's baseline behavior, how they normally act, and they would be the first one to notice the difference. So we definitely want to raise awareness and education in staff and family. We want to also be able to effectively identify the patients that are at higher risk, and that's really important, and that's the one way that we can kind of implement prevention strategies. In order to effectively identify these at-risk patients, we can find and utilize a standardized screening tool for each patient to identify their risk. Lastly, we want to develop and implement evidence-based practice prevention strategies and put it in a nice, neat nursing care bundle to add to their care plan, so that all team members, family members are aware of what the plan is, so that we can ultimately reduce delirium cases in this patient population and increase their patient outcomes. So I kind of went over the rationale, is that pediatric patients, although it's not as common as adults, they can suffer from delirium in the hospital setting, especially if they are ill and require a longer stay. especially in the department that I work at right now. For clinical hours, the pediatric oncology patients, a lot of these patients stay for quite some time, and their routine is very disrupted. A lot of times delirium, because staff are unaware, family members are uneducated, unaware, delirium can go undiagnosed and or unrecognized, and if that happens, we don't treat it, and it just results in those negative outcomes. And lastly, delirium can be prevented in certain cases, especially if delirium is related to sleep disturbances and medications. We can identify these patients who are at risk and do things to change that so that we lessen the risk of delirium. So the PICO question here is, does the use of a nursing care bundle set reduce the incidence of delirium in this population? And that's what we're set out to answer and hopefully implement. So sleep disturbance. Sleep disturbance is one of the reasons that can put a patient at higher risk for delirium. Sleep disturbance and delirium has been found to have a cause and effect relationship. And with that, it has been found that early detection, along with low-cost treatment strategies, prevention protocols, can be effective in reducing the sleep disturbances, thus reducing the risk of developing delirium. Another strategy is effective screening, and we talked about utilizing screening tools to identify higher risk pediatric patients. So delirium is difficult to recognize and diagnose in these patients, goes untreated. If we properly identify these risks on a regular basis, after getting to know the patients, after they've been in the hospital for a period of time, that can lead to early identification and early treatment or intervention prevention strategies. Some of the risk factors that we kind of talked about already is the acuity of illness, the patient's sleep health, and pharmacological treatments, as well as pain. These are the main risk factors for our pediatric patients developing delirium. So some of the prevention strategies that we can implement and include in this nursing care bundle is we can make changes in the hospital environment to where it's more calm, less activity, less noise, just the lighting, things like that, to create a more restful environment for these patients, as well as looking at pharmacological solutions. Are they on, looking at their medication list, are they on benzodiazepines? What's the need for them? Do they really need them? Also, if they're not, can we induce better sleep habits with pharmacological strategies such as melatonin, things like that. Also, we can look at strategies to minimize sleep disturbances, like bundling care, bundling our medication management. If they're, for the most part, stable, maybe skipping vitals or putting them on a continuous monitoring so that we don't have to continuously go in there, or blocking out a period of time where we're not going to disturb them. Those are other strategies that we can put in the care bundle, as well as looking at the delirium education that our staff and family receive. Can they get a printout, some sort of packet, things to look for, signs and symptoms, and when they should notify staff and doctors. So going into my recommendations, for this, I would like to create a task force team that consists of interprofessional staff members, doctors, nurses, techs, especially child life experts, therapists, the pharmacy, and a parent advocate for families. That would be great to kind of have, not specifically the actual parent, but somebody who represents families to be part of this team. to meet initially, come up with some of the issues, come up with make sure that we are addressing any issues that arise, determining which screening, making sure each department knows which, like the nurse knows which screening tool to use, and things like that. And also going through regularly meeting just to go over, okay, what things worked, what didn't work, what are the barriers, and trying to overcome that so that we can stick to our nursing care bundle and eliminate some of the barriers that may arise. Another recommendation is, we talked about early identification. So we need to make sure that our nursing staff appropriately screen our pediatric patients based on their age. There's different identification tools, risk tools to use based on their age. And ideally, you want to do the initial screening about 4 hours after patient interaction, after you've had a good bit of time to kind of get a feel for what their baseline is, and then do the initial screening. And it's even more importantly is after you get that baseline to reassess every 8 to 12 hours to see any changes in their baseline, and note that as well. And as well as talking to the parents so that they know, and they're looking, every so often to see any changes, neurocognitive changes, behavioral changes, and things like that. Lastly, in this instance, educate the staff on the appropriate use of screening tools, making sure that they're doing it in those correct intervals, using the right tools, so that we can do early intervention. Another recommendation is to create and utilize the Nursing Delirium Prevention Care Bundle set based on EBP practices. So once we identify these patients, we want to implement the nursing care set so that we can regulate their sleep-wake cycle by, like I said, not disturbing them at a certain hour, bundling nursing care medication administrations, reviewing medication necessity, taking them off of benzodiazepines if not needed, adding melatonin or anything else that we can safely add to help promote sleep, and also educating the family on this bundle care set so that they know what to expect. So the evaluation, we get to the evaluation piece, how do we know whether this is working? So obviously that is going to be gathering data. What are the cases, as far as how many cases of delirium were on the floor during a set period of time prior to implementation of the prevention protocol. And then we'd go ahead and implement that protocol for, let's say, 6-month period, gather and analyze the data afterwards, compare the numbers pre-implementation, post-implementation. Also, in between time, regularly doing those, having those task force meetings to try and update any information or any protocols that need to be changed to get through barriers, and as well as consistent screening and implementation of nursing care set based on data collected from EMR, having the nurses make sure the nurses are implementing the numbers in the tool assessment each shift, making sure that they're entering and making sure that they're bundling their care. We can gather that information from the EMR, from their charting. So expected outcomes. So as a nurse, providing care in the pediatric oncology unit, we want to give them they have cancer, so we want to give them the best outcome, best chances of recovery without adding one more issue such as delirium to halt their recovery. So, and a lot of this prevention is minor changes, minor things that we can do, cost-effective changes that we can do to identify and prevent delirium through consistent use of screening tools at the set intervals that we identified, consistent implementation of preventative nursing care bundle set based on positive screens, and hopefully the overall reduction in pediatric delirium cases on the unit. With the consistency, we'd like to to aim obviously as close to 100 as possible. So we want to take a look at that. If we can get over 90% initially, that would be wonderful, and then slowly kind of inch up with strategies and meetings to determine what works and what's not, and the barriers, so that we can overcome and hopefully get to, you know, close to that 100% implementation. So conclusion, so delirium is preventable. It can be achieved in certain cases, and it can be achieved through collaborative efforts, through interprofessional staff, a team effort, along with great communication with family, great education as well, and proper and consistent screening and implementation of nursing care prevention strategies. So we can reach this, we just have to work together. Thanks for your time.